Again, welcome. Thank you for joining us for the Robert Wood Johnson Foundation Systems for Action Research Program and our recurring webinar series, Research in Progress webinar series. My name is Glenn Mays. I'm a professor here at the University of Colorado and have the privilege of directing the National Program Office for Systems for Action. And we come to you a couple times a month with this webinar series. It's a chance to hear from one of our funded research projects and take a peek behind the curtain to find out what's being learned through these studies as they progress through the projects. If you're new to Systems for Action, we are a national signature research program of the Robert Wood Johnson Foundation. Our mission is to study innovative ways of helping to connect and align the nation's fragmented medical care, public health, and social services systems, with the goal of helping those systems work across sectors to advance the cause of health equity, to dismantle forms of systemic racism and injustice and inequity that tend to get embedded within our delivery and financing systems for health and social services. So when you tune in this webinar, you're going to hear about an innovative strategy being tested to connect these different types of systems. And you're going to hear about rigorous scientific research to help us learn what works and what doesn't in helping to connect and align these different systems. So today we are really excited to be featuring a project from our collaborators and colleagues up in Connecticut who've been studying the connections between public transit and treatment and services, particularly for populations that experience substance use and mental health issues. Wonderful team. We've heard from this team before along their journey of conducting this research over the last couple of years, and glad to be able to have a chance to check back in with this group and find out what they're learning. So I'm going to turn it over to Dr. Jeffrey Cohen at University of Connecticut, one of the leaders on this study team, to take it over. Jeffrey.
Thank you very much, Glenn, for that introduction. And this is the culmination of 3+ years working on this project together, and we've really enjoyed working with your team at S4A over the course of this project. So just to give you a little bit of background, I'm an economist. I'm a professor at the University of Connecticut in the School of Business. In the School of Business, we have a finance group that, in addition to mainstream finance, we have health economics and real estate economics. And so my expertise kind of straddles all these areas. My past experience includes research on substance use treatment costs and other public health issues, including a variety of other studies related to transit, and so this project has enabled us to sort of blend the areas of expertise that I've enjoyed working on in the past couple of decades. We have another team member here today who is going to serve as the commentator for after our discussion. And he's one of our community partners. It's Stephen Hewlett, who is currently at the Capital Region Council of Governments, which he serves as the Public Health Emergency Preparedness Grant Manager. And he has also taught at the University of Connecticut. And before he joined the Capital Region Council of Governments, he was a local public health director for 25 years in the West Hartford Bloomfield Health District. And the West Hartford District is part of the study area that's considered in this project. Very important area. There's a substantial amount of diversity in terms of demographics in parts of these two towns. And so he's a significant contributor to the community-based research aspect of this project. So just to give you a little bit of background about what we do in this project, as I mentioned, equity and demographic issues are important areas in our geographic region. access to quality healthcare is an equity issue. And part of the concern here is that there are some towns in the greater Hartford area that are very demographically diverse, significant populations of people of color, including one area in New Britain, Connecticut, where there are substantial numbers of people who need access to medical care and specifically substance use treatment and mental health care. But many people in New Britain do not have the ability to afford a vehicle to drive themselves. Um, and even if they were able to afford the cost of owning a vehicle, so in many cases their condition would make it difficult for them to drive to appointments in the broader region. So this led us back in 2020 when we started thinking about this. We actually 2019 when we submitted our proposal, we thought, well, maybe we could look at some of the new transit that has been implemented in Connecticut, and try to get a sense of whether or not having new transit and would enhance access to treatment for people, and possibly improve equity through giving people better access to care. Um, and so this is something that we thought long and hard about, and we decided to move forward with the proposal. And we're grateful that it was funded back in April or May of 2020, and enabled us to really focus on these issues intensively for 3+ years, and try and sort of get an understanding and doing some quantitative analysis as well as community-based research, to understand whether or not having a substance use disorder treatment provider near a transit line would do a few things. One of them was, would it increase patient volumes at these providers? Another one was, if it could make it so that a lot of clients would have the ability to get access to care on time and not miss appointments and not be late for appointments. That might reduce the time that clinicians were sitting idle and not able to bill for those clients, and in turn make it more cost effective or cost efficient for those providers to operate. And so that could leave more resources in society for treating more people, for instance. And the other issue that we thought about with this is that if you integrate mental health and substance use disorder services, are there any cost savings? And the idea might be similar to what we said before. If somebody takes the effort, if a client takes the effort to travel for half an hour on a transit line to get to a provider, it might be a lot easier for them to get treated for multiple services at the same location, and therefore, again, make it as possible that they don't miss their appointments, that they don't, less likely that they would be late for appointments, and that could lead to cost efficiencies as well, which could in turn, make it so that there's more resources in society for people to be treated who need treatment. And finally, we look at whether or not these three sectors of medical care, public health, and social services could come together and try and have discussions and interactions about how these systems might be aligned in order to achieve some of the goals that we found in the quantitative analysis of the research project. And so this type of community-based research is something that we spent substantial amounts of time and effort cultivating and really getting to know each other. And we'll talk a lot more about that in a few minutes. So what were our accomplishments over the 3+ years? One that we're very proud of is that we just recently, meaning in like the past week or so, had a paper a research article published based on the topic of our project, and it was published in the journal Health Services Research, which is one of the more prominent journals on this topic in the public health profession. And this journal ran a special issue on systems alignment, and it was edited by the Georgia Health Policy Center at Georgia State University. Several of their prominent faculty edited the special issue, and I believe we might be able to share a link with you in the chat to the article if you're interested in looking at it more, and we'll also send that out in a subsequent email um, for all of you who want to take a closer look at the article. I'm going to go over some of the highlights of it in a few minutes. But this special issue, they issued a call for proposals a little over a year ago, maybe probably a year and a half ago. We submitted it. We got well, actually, they first issued a call for abstracts. We submitted an abstract. They seemed to like it. We then submitted a full paper after we were invited to submit a full paper. We went through, I believe, 3 revision requests. So you can believe that it was really vetted thoroughly, and then it was accepted late in 2023 for publication, and it just came out on the journal website just within the last week or so. So please feel free to take a look at this, and when you have a chance later on, we'd love to hear your feedback and any comments you might have on this study. It really represents a tremendous effort on the part of our team, and we're very happy that we've been able to make this accomplishment. Another accomplishment that we've had is that we convened leaders from 3 different state agencies, including the Connecticut Department of Mental Health and Addiction Services, from the Connecticut Department of Public Health, from the Connecticut Department of Transportation, also, of course, from the Capital Region Council of Governments, and then from universities, including University of Connecticut and also UConn Health, which is where our co-PI, Dr. Carla Rash, is based. UConn Health is the medical school for the University of Connecticut. We have also a physician from Yale University on the team, on the panel. And we have representatives from 5 local treatment providers that are on this panel. And the objective of this panel, we had monthly meetings from May 2020 through December 2023, and we may keep them going moving forward. But the objective was to try at first to get to know each other, feel comfortable talking with each other about issues, get feedback on the quantitative research that we did that ultimately ended up in the form of a journal article. And then also, hopefully moving in the direction of trying to get some sort of system alignment going. And these meetings were very helpful. By the end of the time period in December of last year, we had felt very comfortable with each other. I would say one of the important things is the regular interaction. If you just, as a researcher, I could envision calling up state agencies and trying to see if there's opportunities for system alignment, but that would never have worked in the same way as if we had just sort of gotten to know each other and talked about issues that are important to all these agencies. And so we're really grateful for this advisory panel that has enabled us to move forward with the research, as well as some parallel efforts that we'll talk about a little bit later. One of the efforts that we, as the advisory panel, undertook was a major grant proposal, multi-million-dollar grant proposal through the National Institutes of Health. They have a community-based scholarship program called Compass, and we submitted our team that was comprised of people from our advisory panel submitted a proposal called Transit and Housing: Eliminating Treatment Outcome Disparities for Addictions. And unfortunately, this project was not funded, but we're hoping that maybe we could resubmit in a future call for this. We got really great comments, and we just came very close when we got the scores to the threshold we would have needed. So we feel that we could address these comments and hopefully have a shot on another round. And of course, if we keep our advisory panel going, which we're hoping we can do, this will facilitate our moving forward with that direction. And this grant proposal was led by Department of Mental Health and Addiction Services, together with UConn Health, and Yale University. And what we proposed was a transit toolkit to build on some of the work that the Department of Mental Health and Addiction Services has been doing, where they essentially bring services to individuals who are frequenting transit stations in New Haven. And our objective was to bring this to other parts of the state, to transit stations in other parts of the state, often in addition to offering substance use disorder treatment and behavioral health treatment, also to offer services to the homeless population. And a key element of this was to try and address the needs of racial and ethnic minorities among people who were aged 18 and above in these neighborhoods near the transit stations in Connecticut. So there is already some effort going on in parallel by the Department of Mental Health and Addiction Services, which we'll talk about in a couple of minutes. But this would have expanded it, and these objectives are something that we really hope we can pursue further in the next round of call for this research. We've also had a number of conference presentations and citations in the press. I was interviewed and featured in a story by the Canadian Broadcasting Corporation in April of 2023. And we also one of us made a presentation at the International Health Economics Association Congress in South Africa a couple of years ago. There were a couple of other domestic presentations we were invited to, and one of them was canceled due to the pandemic, but another one was done virtually. The Tennessee Homeless Consortium in Memphis, Shelby County. There was one of their representatives heard one of our earlier research in progress webinars and invited us as a follow-up to make a presentation to their group virtually, which we did. And just because the project is officially ended does not mean that we are not planning to disseminate the work further. We have submitted an abstract to the NACCHO conference, which is to be held in July 2024 in Detroit. We've submitted the abstract, awaiting a response. We hope we can continue to engage with people and make our work widespreadly known. And then, of course, we've done regular Systems for Action webinars, including annual grantee meetings, research in progress meetings, think tank meetings over the last 3+ almost 4 years. Well, we've undertaken a broad range of research activities, some of which I haven't described above already, but the research activities that we undertook included traditional quantitative analysis using statistical techniques called regression, and I'll talk some more about that in a few minutes. And then, of course, some community-based research, which looked at system alignment efforts. And there were also a few parallel research efforts that evolved during the time period that we undertook our project, and I'll mention some of those in a few minutes. But I want to spend a few minutes talking about the research approach that we took. And so what we did was we said, okay, let's follow a framework that has been used in other industries, not just in terms of medical and public health sectors, but other industries like the manufacturing sector have used this. It's called the production process approach. There's been a broad literature on hospital operations that have used this as well. And so there have been some studies on substance use disorder that have used this cost approach or production approach, where you take a bunch of different inputs to the treatment process, which includes the buildings, the any equipment, that's the physical capital, and then you combine that with workers who are clinicians, physicians, and other healthcare related workers, and then you pull in social services, which could include strong transit and transportation systems, and you combine them all together in a treatment process, which is sort of the center of this diagram, and you get a variety of outputs that are sort of spit out from this process, which it might include the number of admissions or discharges. It might include the number of completions that you have of treatment. And there could be other outcomes as well. So this is where we pull in all the three sectors that are involved in this process, including social services. Social services is comprised of transit, for instance, and other transportation. Of course, it could include housing. We did not specifically drill down on other social services, as our focus was on transit. But then, of course, public health outcomes are one of the key metrics we were trying to look at later on as well. And so on the right side of this screen is an aerial photograph of the 4 towns that are covered by a new transit line that opened in 2015 in Connecticut called CT Fast Track. CT Fast Track is a bus rapid transit line that serves New Britain, Newington, West Hartford, and Hartford, Connecticut. Hartford is the state capital, for those of you who aren't familiar. There are 11 stations on this bus rapid transit line, and it follows an old an extinct freight rail right of way. So it's essentially a bus line, that rapid transit line, that does not have to drive through traffic for the most part in city streets. It can so you know exactly what time the bus is coming and is expected to get to each destination on the line. So it's very reliable, and it's a line that enables people in places sort of further south, like New Britain, to have access to jobs in Hartford and West Hartford, and also to achieve opportunities to get medical treatment and other health needs met by being able to have access to providers in these towns. We have information from the Department of Mental Health and Addiction Services in Connecticut on the different programs in the state that offered substance use disorder and mental health treatment. And we merged that data with data from the Internal Revenue Service on the operating costs of these providers. And what we did was we said, okay, let's look at within 1 mile of each station, which is a reasonable distance to expect people to go once they get off a station and need to receive, get to their treatment location. And this 1 mile radius showed us that we had about 17% of the programs in the state were within 1 mile of a station, of a CT Fast Track station. And what we did was we essentially did we had a quasi-experimental quantitative regression approach, where we had a treatment group of providers, and the treatment, when I say treatment, think of an experiment where you have a treatment group and a control group. Okay, the treatment group is a group that receives some sort of policy change. The control group does not receive the policy change. So if you're within 1 mile after 1 mile of a station, if you're a provider within 1 mile of a station after the opening of this new line, then you're in the treatment group. That's what how we defined the treatment group. And everybody else, which is say beyond 1 mile in the whole state of Connecticut, is part of the control group. And we use this treatment group to try to look at what is the effect of being in the treatment group on the operating costs of providers, after the opening of the new rapid transit bus line. And what we find is that there's a significantly lower operating costs for providers that are near the new transit after the opening of the transit. And we also explored the issue of the multiple services at the same provider after the opening, and we find that evidence that it's less costly for providers to treat multiple services at the same provider after the opening. And in addition, we find that there were more clients who were treated at providers near the transit after the transit line opened. So it seems like the transit line is having a significant effect not only on the ability for people to access care, which we said is an equity issue, right? Because if you can't access care because you can't get to an appointment without a car, then that's not equitable. But it also has an opportunity to make treatment more cost efficient for providers to offer. Now, we did not find a significant effect on treatment outcomes, and I'm going to talk a little bit more about that. I think we want to drill down in that a little bit more in any follow-up work that we might want to pursue. And in addition, the advisory panel, which has been meeting regularly, and we've been sharing our results as we go along and interacting with them, and the same time trying to pursue some parallel initiatives. Some of us on the group have. They have been instrumental in saying, well, why don't you try this little tweak to the model, or why don't you add this variable or take that variable out? And so this has really been a collaborative effort with all the different systems. So as I mentioned, there are some parallel efforts that are going on. This includes an effort led by Dr. Carla Rash, who's the co-PI on our project. She's leading a alternative first responders project for the city of Hartford, where when somebody calls 911, for instance, clinicians in her project, she had clinicians responding instead of law enforcement, and it's been a tremendously successful program. She's told us that now some individuals call this number, and they actually ask for specific clinicians to come and respond, which is really amazing. And Dr. Rash is being honored right now as we speak by the city of Hartford, which is why she couldn't join us for this presentation today. So this is one of the parallel efforts. The other parallel effort is led by Dr. Kimberly Caranda from the Department of Mental Health and Addiction Services, where her team is collaborating with Connecticut DOT. Dr. Caranda is also on our advisory panel, and that's the existing program where they're bringing services to people who are frequenting transit stations in the New Haven area. And again, this has been very successful. They meet people where they're at in terms of their desire for treatment, for willingness to agree to be treated, and they're offering not just mental health and addiction services, but offering people opportunities to connect to housing for those who are homeless, for instance. And so that's sort of what we built upon for our NIH proposal that we submitted, and that we're hoping to follow up on again later at the time of the next call for proposals on that topic by NIH. There's some possible next steps for future collaborations between agencies in the state, UConn, and the providers. It might be interesting to explore other transit stations in the state of Connecticut, because the greater Hartford area is one area that is in the central part of Connecticut, but there are many other urban areas in the state that, Connecticut is sort of an interesting state in the sense that we have a number of smaller cities. They're nothing like the size of New York or Boston, but we have cities that are smaller that have large populations of people of color, and so there could be opportunities to try and enhance the ability of people in some of these other cities and towns to receive treatment, and so we would like to study other transit stations in a similar way as we've done here to see, for instance, if we do see benefits to having these systems aligned. And incidentally, in Connecticut, we don't know that these systems were aligned intentionally in terms of the greater Hartford region, but what we're demonstrating here is that it seems to have made sense if you look back and look at the impacts of having transit near substance use and mental health disorder treatment. And of course, aligning systems not just in the Hartford area but in other parts of the state could help alleviate the huge public health issue of the opioid crisis. And so that's another aspect of the three legs: the social services, medical, and of course public health, that are important in aligning systems. Another possible next step is to try and incorporate affordable housing. And we might consider exploring partnering with the Connecticut Department of Housing and another housing organization called the Connecticut Housing Finance Authority. And another issue is outcomes. We did a little bit of exploration with outcomes, but it may be the case, if you spend more money on clients, that might impact, if the money is spent well, that might actually impact treatment outcomes. So we want to explore some of these outcomes, and NIH has different outcomes called national outcome measures, NOMs, that that they use, including the ability to hold a job, the ability to maintain stable housing, and others that we could explore and try to see if there's a bi-directional relationship. People who, for instance, have better housing, it might be easier for those people to be treated, and therefore that might cost less to treat them. But at the same time, if the governments, local governments, spend more money to provide services, that might lead to better outcomes as well. And then, of course, another big issue that we would like to drill down more is to try to obtain information on the demographics of the individual patients, and try and get a sense of how the possibility of structural racism may be at play here. The data we currently had gave us information on the average demographics in each provider, but if we have individual client demographics, we might be able to do a lot more. And so that would involve another sort of data gathering initiative. Finally, I'd like to extend our thanks to Systems for Action and the Robert Wood Johnson Foundation for your ongoing collaboration on this. Your staff has been fabulous. And we also want to extend our appreciation to our advisory panel members from all the agencies, all the state agencies, the universities, and the other organizations that were a part of this. And we want to give a special shout out to the Connecticut Department of Mental Health and Addiction Services for sharing a big chunk of the data that was needed for us to be successful in this project. Thank you very much.
Fantastic. Well, we are now at the question and answer portion of our session today. And again, we invite folks, if you've like to ask a question, hear more information about what you've heard from our team today, we invite you to use the Q&A box, Q&A icon you should see down at the lower portion of your Zoom screen. You can type your question in there, and we'll get to as many of those as we can today. And
Glenn, maybe after Steve finishes his commentary, maybe there will be more questions. I don't know if you'd like
Yes,
him to go ahead now, or
I think that would be great. Why don't we do that? Steve, would you like to uh, take the floor and add your perspectives?
Be happy to. And as Jeff said, thank you to all of you and your staff and Robert Wood Johnson Foundation for giving us this opportunity to do systems alignment and to pull together what turned out to be, I think, a very successful advisory committee. So from the community provider perspective, Jeff outlined who all those folks were. And it was interesting to align system providers who sometimes may be thought of being competitors to actually be collaborators. That was a wonderful success. The challenge to that was the commonality of the problem of access and getting people and their clients to their facilities. And what does public transportation with this new natural experiment called a busway? What can we observe from that? So as Jeff mentioned, those early days of our meetings were sort of finding that common ground of how does access and transit work. And we heard a whole array of how that happens. Certainly the Department of Mental Health and Addiction Service gave us outcomes about the individual clients and the services provided. The Department of Social Services is the one that provides transportation through a very large contract, as we found out. That is there in order to assure that people have the option to get there. However, not all the providers were satisfied with that system because it was sort of a single point of service. As Jeff said, going for multiple services didn't fit in maybe necessarily to that contract and that system. So there were some issues which created the desires by some of our providers during our time to talk about how they were using private ride services like Uber, which would be an expense to them, or how they were using, trying to get family members to do it, which can be maybe a difficult challenge for the client themselves. And then one group that was part of one of our provider groups actually was successful in getting a grant to get a van, which sounded like, well, that's another natural experiment we can look at. How does that help? Only to find out that after only having the van for a number of weeks during COVID, it got vandalized. So the brand new van ended up not being functional and, of course, increased their costs. So we learned a lot about their experiences. And Jeff and the researcher staff were patient in listening to, I think, all of that sort of information while we sort of got it together. And the state health department staff, all the state health department staff were very forthcoming and not being defensive about the programs they ran. Everybody's looking to get things to be good, better, best. And if we can get there, it was going to be thought of as being a great idea. The Department of Transportation was terrific along the way. As we looked at and learned more about the benefits of transit-oriented planning, which is generally sort of thought of as an economic development type of tool for communities. But in fact, we can demonstrate now that there's a service benefit to transit-oriented planning, which might be another one of those things we look for in the work ahead. Plus just the idea that here in the Northeast in particular, but across the country, most of our traffic planning has been oriented to cars and moving cars quickly, but it hasn't looked at the purpose of why the people need to go to these places. So the Complete Streets programs in Connecticut have been very active in all 4 of these communities, where they're trying to make pathways for bikes and people to walk, and obviously public transit. So the engagement of some of those concepts amongst the advisory panel, I think further aligns systems, so that we're talking about community-based policies, not just state-based policies. And we did have we have attracted the attention of maybe being able to present to some of the standing committees that are appointed by the legislature. So we were looking at exploring some of those activities during the summer while the legislative session was out here in Connecticut. And those might be future presentations where we could have an opportunity to share some of these findings and hopefully sound ideas for moving forward to how we can get people access to services safely, efficiently, effectively, and how those services can then produce outcomes that are more successful and long-term. So the advisory council, I think, was terrific. We lost some people to attrition, but we didn't lose any agencies. The next person would step in and take place. And as we talked just recently, we did all this during the middle of COVID. So the advisory panel, as dedicated as they were, we did it all virtually during the entire time, which also led to the fact that we learned a lot about trying to get telemedicine into substance use treatment. Because that all happened while we were doing this research too. It didn't impact our research questions, but it may have impacted ridership. It may have impacted other components of our study. So we have talked about, geez, maybe we have to come back and revisit this, when the skies are a little bluer, and see actually, my guess would find the impact would be even larger to the benefit of why public transit is beneficial. So all right, that's just sort of the commentary of our 3-year experience. Jeff's leadership was terrific. We did stay on a schedule. We basically would set out a schedule for the year and held to it. It's easier to schedule meetings and then cancel them than it is to try to schedule them off calendar. And folks were really diligent about meeting us for those calls. And I appreciate everybody's willingness to let me ramble on here today, and be welcome any questions you might have about the community-based aspects of the process. And thank you once again.
Fantastic. Thank you so much, Stephen. Really, really helpful perspectives on this project. So as promised, we do have some time for Q&A, and we've got some questions that are starting to flow into our Q&A box.
Sure. Should I go ahead and jump in, Glenn, or would you
I
like
think that's fine, Jeff. You could see these. So yeah,
yes.
if you want to take the first one.
Okay. So one of the first comment that came in asked what other suggestions the advisory council had, and how much it differed from the original plan. Was there a qualitative aspect like listening groups? So let me answer the last one. We did have 5 treatment providers on the advisory panel in addition to the state agencies. So we certainly had lots of opportunities to listen to issues that they were facing. Some of the anecdotes that Steve talked about, like they're using the Ubers and the the anecdote about the van that got vandalized and that made it more difficult. And there was actually one treatment provider that told us sort of halfway through that they decided to pursue purchasing a building near a train station in the center of Hartford. So there, that we had these opportunities to listen to the community providers. We did not specifically listen to individuals who were being treated. That might be interesting in future work to look at. In terms of the strategies that the advisory council had, there were a couple of interesting. There were many interesting strategies, but a couple that stood out in our mind is that we had these great ideas, we had these research findings, but in order for state agencies and treatment providers to try to implement some of these suggestions for further system alignment, really there's funding would be needed to do this. And that's kind of what set us on the path to pursue this NIH proposal that we explored, because that would have enabled us to hire staff to actually implement some of these alignment strategies in a broader geographic scope than was already being done in the parallel efforts in the state. So basically, having these ideas are great, but you really need to be able to implement them, and to do that is you need funding. The other aspect was that having this group together was really helpful in trying to network with getting the right people on the panel. So we started out with people who we might have had a connection with at some of these agencies, and then after a few months, a couple of them said, you know, I know this really great person at the Department of Mental Health and Addiction Services who would be perfect for this, who is actually trying to do some parallel efforts, and that's how we met some of the people that we sort of gelled with towards the later part of the project. Through that interaction. Another question came up here, were any of the partners hesitant to be involved in transportation? It looks like this person is asking, maybe a challenge. So one of the benefits to having sort of a small state like Connecticut is that you know, we've had an opportunity to work with other state agencies. And to give you an example, I've been doing research on this bus rapid transit line for about the last 7 or 8 years or so, with the Connecticut Department of Transportation's support, to look at the impacts of this bus line on real estate in the greater Hartford area. And so when it came time to form this panel, the state agency, the Department of Transportation, was already very interested in issues related to this bus line, and they were actually eager to have a representative come to the table on this. So I think if you can engage people in your team that have prior experience working with some state agencies, I think that's one way to try to pull in some interest among those other organizations.
Yeah, Jeff,
We-
I would just add, from the Department of Social Services side, the history with the contract for providing service transportation to those that needed it has become a highlighted topic for the legislature because it's a big ticket item. They had recently changed vendors because they were dissatisfied with that. So they were very interested actually in having that program data explored. They weren't hesitant about it. And those reports are actually public reports. So we were able to actually access the data that were the questions the legislators were asking to see, delayed in times or missed appointments, and this, that sort of data was all collected there. Maybe not exactly to substance use treatment per se, but we did access that data, and the Department of Social Services was open to letting us have it. So I'd say the transportation issue was a common ground for all of our providers.
Yes, definitely, Steve. A couple of other questions popped up about looking at other transit. We did not look at other bus lines within the city of Hartford, but that could be something worth exploring further, to try to see how people sort of within Hartford are moving. This is mainly this bus line enabled us to look at people who are sort of outside of the city, who might have had no other way to get into the city, and get in there quickly. Because if you can, get on a bus that has absolutely no traffic, you can get there very quickly. And so that's why we chose to focus on that. And the other aspect of this that was attractive for this problem was that it was like a natural experiment, because before 2015 there was no bus line, and then suddenly you have a bus line, and so things change all around because of this new thing, the bus rapid transit line. The individual bus lines would be interesting. It's a little bit more challenging to disentangle because most of them have been there for much longer, but we could explore that, and we should explore that. In terms of having to pay for a transit card, Steve, I think you might remember, were people
Yes.
given cards by the providers?
Yes, that's an option. It's an option through the state contract, actually, that they can provide transit cards. I think it was up for 30 days or something to that effect. So part of the state contract can award that, and then some of the providers also add that as an option that they could provide public transit cards for, I think it was 30 days. I could be wrong, could be 60 days. During the COVID, of course, for a little while, our governor suspended fees. for public transit to try to encourage people to do that. So that has since expired, but that was an option for a little while during the COVID process, where the fees were just flat out waived. So anyway, I think that the transit line question is an interesting one, because it make it more difficult for our research team. The bus line platforms are a fixed location, so it's easy to say distance wise to do that equation, whereas the bus routes would be loops, and it might be harder for us to figure out exactly where on that loop did we get that client or that patient, or where's that benefit. But it's a good question. It was something that I think we talked about, some of the satellite bus routes that are part of the busway to get to major like shopping centers and food supermarkets and whatnot. But we didn't really look at that from a provider perspective.
One thing to add is, people might wonder, well, why didn't we look at the COVID period? Because there were major structural changes then. So this project was, we submitted our proposal in the fall of 2019, and it was funded in April of 2020. And so at that point, when we started, there was really no data, and we really didn't know anything about COVID at that point. And sort of we went down this path. The COVID period, I think, would be interesting to look at in follow-up work. And now that the COVID period is over, the governor has lifted the suspension of the transit fees, so those are back in place. So lots of interesting questions to follow up on. And as this has evolved over the last several years, more questions have come to our attention. So we appreciate all of that. Thank you.
Really, really great work. I want to ask a follow-up question. I wonder, in thinking about the problem and the collaboration that you pulled together to tackle this problem, there's one approach is thinking about how you can build transit lines to get people closer to services. But potentially, it strikes me this collaboration could also affect the decision-making of mental health and substance abuse service providers about where they locate, and are there incentives for them to locate closer to transit rather than necessarily always trying to bring transit closer to the service provider location. So any thoughts about whether your project is affecting decision-making about clinic locations among mental health and substance abuse providers? Is that part of the conversation here?
We did, and I'll take both the credit and the blame for this one, but we tried to explore the certificate of need process here, and tried to see if transit was one of the criteria for certificate of need.
Yeah.
And we were unable to actually get a solid conversation with the group that does that, which is actually the Office of Healthcare Access, which is a offset of the Department of Public Health and sort of the governor's office. During COVID, they were just closed, to be honest with you. So we couldn't get to that answer. But that would be a logical place where, if you're trying to expand your service or create a new service, that at least one of those questions are distance to public transit, or do you have access to public transit? So yes, Glenn, I think that's a fair question and a fair policy challenge for places that have certificate of need requirements.
Yeah, and I think one of the other interesting things, during the course of our project, about halfway through, one of our treatment providers, I think I mentioned this before, they decided to purchase a building that was right next to the Union Station in downtown Hartford, and that happened sort of in parallel to our advisory panel meetings, and then the other in parallel activity was the activity that the transit hop activity that the Department of Mental Health and Addiction Services was undertaking, where they actually brought clinicians to the train stations to try and help individuals in need there. So even though they didn't physically move the buildings, right next to the station, that is something that they did in a different way. And that's the foundation for the Compass, the NIH Compass grant that we had proposed to expand on that, which hopefully we'll have another opportunity to revise and go for that again in the future round. So
fantastic. Well, this is really very interesting, very important work. I want to thank our team from Connecticut again. Thank you so much, Jeffrey and Stephen, for being with us today, sharing with us the evidence and insight coming out of your project. Well, as you mentioned, your dissemination work is ongoing, and we'll continue to look for more work coming out of this project, and definitely continue to stay in touch as you look at next steps and follow on some of the follow-on studies and projects you mentioned today. So as we wrap up, again, a reminder, if you want a certificate of completion for today's webinar, you can complete the survey at the end of the session and receive an email of that. We also want to make sure everyone's aware that our 2024 call for proposals for new research is open, and we are accepting proposals for new research to be funded under the Systems for Action Research Program. So we encourage you to go to our Systems for Action website for all the details on that, how to apply. Again, our website, systemsforaction.org. This call for proposals has a deadline of February 7th for submitting the required three-page letter of intent. So keep that in mind. You've got a few more weeks putting your ideas together and submitting an initial letter of intent for this funding opportunity. We also do weekly virtual office hours, and you can drop into any of those office hours over the next couple of weeks to ask questions or seek guidance from our S4A team. So we hope to see more applications there. And of course, tune in for our upcoming webinars. We come to you about twice a month with these webinars, and you can see our webinars for February listed up on this slide here. Definitely hope to see you all again with us in a couple of more weeks as we get into the month of February. Thanks so much, everybody. Thanks to our team again from Connecticut. We'll look forward to staying in touch. Enjoy the rest of your day. So long, everybody.